Hello, I'm Roger Henderson. I'm a GP in southwest Scotland, and I also co-host the GP Notebook study groups. Welcome to the GP Notebook podcast, where we discuss bite-sized topics aimed at all those working in primary care. Now, in this episode, I'll be discussing one of the most insidious threats to vision worldwide, glaucoma. This is a progressive optic neuropathy defined by the loss of retinal ganglion cells and their axons. And it's this degeneration that leads to the characteristic changes seen in the optic nerve head and a pattern of visual field loss that's often subtle early on, but irreversible if left untreated. Now, epidemiologically, glaucoma represents a substantial global burden, affecting over 60 million people, with projections exceeding 110 million by 2040. Between 2015 and 2035, the number of people living with glaucoma here in the UK is expected to increase by some 44%. The prevalence varies by ethnicity, so individuals of African descent are particularly vulnerable to open-angle glaucoma, while certain Asian populations face higher rates of angle closure disease. Now, age, as is typical, remains a universal risk factor, and family history, systemic conditions such as diabetes or hypertension, ocular trauma, and steroid exposure all further increase susceptibility here. We can categorize glaucoma in several ways, and broadly, it's either primary or secondary. Primary glaucomas occur without any identifiable underlying cause, while secondary glaucomas are the result of other ocular or systemic conditions. And each can further be classified by the anatomy of the anterior chamber angle, so open angle or angle closure. Understanding these distinctions isn't just academic, it really is critical for the diagnosis, treatment planning, and patient counselling. So, as we said right at the start, at the heart of glaucoma is optic nerve damage. Elevated intraocular pressure, or IOP, is a well-established risk factor and the primary therapeutic target. But it's important to remember that not all glaucoma involves elevated pressure. In normal tension glaucoma, optic nerve damage still occurs, despite IOP readings being within the statistically normal range, pointing to additional contributors such as vascular dysregulation, autoregulatory defects, or heightened individual susceptibility. Genetics also play a role here, as twin studies have shown higher concordance in monozygotic pairs than dizygotic ones, indicating a combination of inherited and environmental influences. So, let's start by discussing primary open-angle glaucoma, or POAG, which accounts for the majority of adult glaucoma cases. POAG develops insidiously, and patients often remain asymptomatic until significant optic nerve damage has occurred. Pathophysiologically, the problem lies in impaired aqueous humor outflow through the trabecular meshwork, and this resistance leads to a gradual rise in intraocular pressure, which can compress optic nerve fibers and reduce perfusion. And over time, this results in the characteristic cupping of the optic nerve that we see and the development of visual field defects, often beginning in the mid-periphery and sparing the central vision until the late stages. Now, clinically, a patient may well present with no complaints at all, which underscores the importance of routine eye examinations. On fundoscopy, you might see an increased cup-to-disc ratio, often asymmetrically between the eyes. Visual field testing typically reveals arcuate scotomas or nasal steps, and in advanced cases, the central vision does become involved, leaving the patient with the classic tunnel vision. Secondary glaucomas are diverse and require careful clinical evaluation, and these can result from trauma, prior ocular surgery, neovascularization due to diabetic retinopathy or retinal vein occlusion, lens dislocation, pigment dispersion, pseudoexfoliation, or steroid use. But in each case, the unifying mechanism is obstruction of aqueous outflow or increased episcleral venous pressure. So, for instance, pseudoexfoliation glaucoma is characterized by flaky extracellular deposits in the anterior chamber that clog up the trabecular meshwork, whilst pigmentary glaucoma involves pigment granules shedding from the posterior iris surface. Steroid-induced glaucoma occurs when corticosteroids increase the resistance to aqueous outflow, highlighting the importance of a detailed medication history. Now, diagnosing glaucoma is, as is so often the case in practice, both an art and a science, involving integrating the patient history, the clinical examination, and diagnostic testing. Tonometry remains central as the gold standard here, and visual field testing, optical coherence tomography, and gonioscopy provide structural and functional insights. Pachymetry is also important as the corneal thickness influences IOP readings and risk assessment. It's essential to recognise too that eye pressure fluctuates throughout the day, so single readings may not reflect the true pressure profile. So diurnal monitoring can help identify patients at risk who may at first sight appear normal during a single examination. When it comes to managing glaucoma, our primary objective is always to preserve vision. Because optic nerve damage is irreversible, the sooner we intervene, the better the long-term outcomes. And the cornerstone of treatment across most glaucoma types is lowering intraocular pressure, and this remains the only modifiable risk factor proven to slow disease progression. How we approach this, however, depends upon the type of glaucoma, its severity, the patient's comorbidities, and even their lifestyle and tolerance for therapy. So for patients with primary open-angle glaucoma, we typically start with pharmacologic therapy. Prostaglandin analogues such as latanoprost, travoprost, and bimatoprost are often the first-line choice for us. And these work by increasing uveoscleral outflow, and their once-daily dosing does make adherence easier for many patients. Clinically, they're well tolerated, although you might see side effects like conjunctival redness, darkening of the iris, or the slightly unusual one of increased eyelash growth. Beta blockers, such as timolol, offer a different mechanism by reducing aqueous humour production. And while effective, they do require careful patient selection, especially in individuals with bradycardia, heart failure, or reactive airways disease, since systemic absorption can exacerbate these conditions. Alpha-2 agonists like bromonidine also decrease aqueous production while enhancing uveoscleral outflow, but ocular allergy and systemic fatigue can limit their use in some patients. Carbonic anhydrase inhibitors, whether topical or oral, are another option. And while oral acetazolamide can be powerful in acute or refractory cases, systemic side effects like paresthesia, kidney stones, and metabolic disturbances do require monitoring. For specific situations, we sometimes employ miotics like pilocarpine, particularly in angle closure disease, although side effects such as headache or induced myopia can make their long-term use challenging. In recent years, newer agents like Rho kinase inhibitors have emerged. These drugs improve trabecular outflow, and nitric oxide donating prostaglandin analogues offer another innovative mechanism to lower pressure. These therapies do expand our toolkit now, especially for patients who are not adequately controlled with traditional medication or who have difficulty tolerating multiple drops. As you'll know, laser therapy can also play an important role, either as a primary intervention or as an adjunct when medications are insufficient. So for open-angle glaucoma, laser trabeculoplasty, whether using argon laser, selective laser, or newer multipulse techniques, enhances outflow through the trabecular meshwork. Selective laser trabeculoplasty is particularly attractive here because it minimizes tissue damage and it can be safely repeated if necessary. In angle closure glaucoma, laser peripheral iridotomy is a mainstay. Creating a small hole in the peripheral iris allows fluids to bypass the pupillary block, relieving pressure and so preventing further attacks. In cases of plateau iris or persistent angle narrowing, laser iridoplasty can be performed to contract the peripheral iris, opening the angle and improving drainage. Surgery typically only becomes necessary when medication and laser treatments are insufficient to control pressure or when rapid disease progression threatens the vision. Trabeculectomy remains the gold standard here, creating a new outflow pathway for aqueous humour. Although highly effective, it carries risks, including hypotony, leaks, infection, and cataract formation. Tube shunts, or glaucoma drainage devices, divert fluid to external reservoir and are particularly useful in refractory or secondary glaucomas such as those caused by neovascularization or uveitis. For many patients across the world, minimally invasive glaucoma surgeries, or MIGS, are now changing their glaucoma landscape. And these procedures, which include devices like the eye stent or canaloplasty, offer a safer profile, quicker recovery, and meaningful reductions in intraocular pressure, particularly in mild to moderate disease. Now, while MIGS may not achieve the same level of pressure reduction as traditional surgery, they do often reduce the number of medications needed and carry fewer complications. For refractory cases with limited visual potential, cyclophotocoagulation targeting the ciliary body can be an effective approach to reduce aqueous production. Management must also be tailored to the specific type of glaucoma, so in normal tension glaucoma, even modest reductions in pressure can stabilize the visual field, and a 30% reduction in pressure significantly slows disease progression. Equally important is identifying systemic contributors such as nocturnal hypotension, vascular dysregulation, or sleep apnea, which may exacerbate optic nerve damage. For secondary glaucomas, addressing the underlying cause is obviously crucial. Neovascular glaucoma, for instance, often requires treatment of retinal ischemia with panretinal photocoagulation or anti-VEGF therapy, in addition to lowering intraocular pressure. Steroid-induced glaucoma requires discontinuing the offending agent whilst managing pressure, and post-surgical glaucoma may necessitate a combination of medical, laser, and surgical strategies depending on the etiology. Finally, no management plan is complete without close follow-up. Regular tonometry ensures target pressures are maintained, visual field testing monitors functional progression, and optical coherence tomography allows us to track subtle changes in the retinal nerve fiber layer. Patient education and adherence are equally critical, since without any consistent therapy and monitoring, even the most effective interventions can fail. Additionally, optimizing systemic health, including controlling blood pressure, diabetes, and other vascular risk factors, can all make a meaningful difference to the outcome. Fundamentally, you can see that glaucoma management is a balancing act. It requires a nuanced understanding of the disease type, progression risk, patient-specific factors, and available therapeutic options. But the ultimate goal here is always to prevent further optic nerve damage and preserve quality of vision. And this demands not only technical skill, but also individualized care. We must always remember that glaucoma is a multifaceted, potentially devastating disease. Early recognition, careful evaluation, and timely intervention are crucial to preserving vision. And while current treatments can't reverse optic nerve damage, lowering intraocular pressure and addressing any underlying causes can significantly slow the disease progression and maintain the patient's quality of life. As GPs, maintaining this vigilance, understanding the nuances of each glaucoma subtype, and personalizing patient management are all essential to improving outcomes with this condition. So that's a quick overview of glaucoma, and I do hope you found this podcast helpful the next time you see a patient with this condition. But do have a look at the show notes that accompany this episode at GPnotebook.com, and we'd be very grateful if you'd consider following the podcast and leaving us a review on your favourite podcast platform. Do feel free to get in touch via social media at GPnotebook or email us support@GPnotebook.com if you've any questions, comments or ideas for future podcasts. You can also visit us at GPnotebook.com to register for our virtual GP Notebook study groups, which occur all year round. And you can also download free shortcuts to help improve the lives of our patients in primary care. But as always, until the next time, thank you for listening and goodbye.